Good morning, Pramod. I'm audible, Surabhi? Pramod?
Good morning, sir. Yes, sir, you're audible, sir.
Yeah, Manu, good morning.
Good morning.
Yeah, we'll just wait for we'll just wait for some more time. We need a little more audience.
Just that I wanted to see the screen share once.
Yeah, please, you can try it.
So the backend team can help me out. I'll
Yeah.
just share my screen.
Yeah.
Shall I set it up on your system now? Yes. No? Okay. Can you see the screens?
Yeah, very well, Manu. Very well. Your screen is visible very well. Yes.
I'll stop screen share for some time.
Yeah. You stop the screen share because we have some small formalities before we start. Actually, a small Saraswati Vandana and all.
Okay.
So it will take some 10-15 minutes.
I'll be online, no problem. I'll be online.
Yeah, you need to be because it's all for in your
Okay.
honor. Yeah.
Fine.
Yeah.
नहीं
Okay, madam. Okay.
Good morning. Am I audible?
Good morning, ma'am. Yes, ma'am, you're audible.
Fine.
We still have a couple of minutes. Yeah, now I have unmuted it because I wanted to speak. Yeah. I just wanted to ask, like there are 36 participants. We'll wait for another 2 minutes, 1 minute. Surabhi, get ready. Just 1 more minute.
Yes, sir.
Yeah, Surabhi, I think you can start.
Yes, sir. Sir, am I visible, sir?
Yes.
Education is the most powerful weapon we can use to change the world. With this beautiful quote by Nelson Mandela, I, Dr. Surabhi Singhai, a postgraduate trainee from the Department of Oral and Maxillofacial Surgery from Chhattisgarh Dental College and Research Institute, Rajnandgaon, wish you all a very warm welcome. And I wish you a very good morning, and I welcome you all for today's intriguing webinar on comprehensive cleft care, cognizing the concepts. I also welcome the Board of Directors, the respected President of our college, Sri Nemichan Parekh sir, the respected Vice President of our college, Sri S.K. Buddhan sir, the respected Secretary sir, Sri Sanjay Golcha sir, and our Honorable Dean ma'am, Dr. Hema Suryavanshi ma'am, to help us conducting this webinar. For this virtuous event, let's take Almighty's blessing and start with Devi Saraswati Vandana. With all the positive energy, let's move ahead. Now I would like to invite the organizing chairman, Dr. Pramod Krishna B. Sir, professor and head of department in the oral and maxillofacial surgery of our college, to welcome you all. Over to you, sir.
A very good morning, everybody. Respected President Mr. Nemichan Parekh sir, Vice President Sunil Buddhan sir, Secretary Mr. Sanjay Golcha sir, and our respected Dean Madam Dr. Hema Suryavanshi, Dr. Manu Prasad and his team, and all the delegates who are going to make this event a very successful one. A very warm welcome to all of you for this webinar on cleft lip and palate. Cleft lip and cleft palate is an affliction of mankind which is seen from prehistoric era, and the treatment of the same has evolved over centuries, and the treating specialities have also been changing. We, as an oral and maxillofacial surgeon with basic training in dentistry, are well versed with basic training with the embryology and anatomy of head and neck, and so are very apt in treating the same. Having said that, management of cleft lip and cleft palate is with multidisciplinary approach. Today, we have our esteemed speaker, Dr. Manu Prasad, with his team, who would give an insight into the concepts of cleft lip and palate surgery. Without wasting much of the time, I hand over this virtual podium. Have an enjoyable and informative session. Thank you.
Thank you so much, sir, for your kind words. When a talent gets good mentoring, there is nothing that can stop it from achieving its goal. Rightly said for our respected Dean, ma'am, Dr. Hema Suryavanshi, ma'am, Head of Department in the Oral and Maxillofacial Pathology. I would now humbly request her to address the gathering. Please, ma'am.
Good morning, one and all. Respected directors, Shri Parak sir, Shri Golcha sir, and Shri Buddhan sir, all our faculty members, all the HODs, Dr. Pramod Krishna sir and his team, and most importantly, our respected guest. I welcome you all for this webinar, and I thank Dr. Manu Prasad for accepting our invitation and providing us his valuable knowledge, for sharing his knowledge. And I'm also, when I went through his resume, I can see that he is very young. So this is good that at such a young age he achieved so many things, and he's a friend of Pramod Krishna sir. That is also good thing, because what I could see is that whoever is friendly with Pramod Krishna sir are very humble people, and they accept our invitation very humbly, and they present us very knowledgeable and very fruitful, very insightful lectures. So thank you sir, Dr. Manu Prasad sir, thank you once again. And I'm what I can see that lots of faculty members have joined from our institute, so I'm happy that so many people are interested and so many people have shown interest and they have joined. I hope this webinar will be of use, will be useful to our prostho department, our pedo department, and all the postgraduate students. They will gain knowledge from this webinar, and I hope in future also we will continue with such different topics. No doubt cleft lip and cleft palate is a very important topic. What I can see is, like, in India we have got more cases than in other countries. So this is a part of social service also. I hope in future we will be able to treat cleft palate and cleft lip patients in our institution with the help of Dr. Manu Prasad. I once again congratulate Dr. Pramod Krishna sir, and I hand over the podium to you, Surbhi. Thank you.
Thank you so much, ma'am, for your kind words and motivating words. Now let me acquaint you to our esteemed speaker of today's webinar. Professor Dr. Manu Prasad sir is a well-known in the field of craniofacial cleft and aesthetic surgery with 14 years of experience. He has over 10,000 surgeries to his credit and many more to come. He follows his unique principle of blending surgery and philosophy. Sir has excelled in craftsmanship in the field of craniofacial surgery, cleft lip and palate surgery, cosmetic surgeries of face and hair transplantation. Sir is the professor and head of department in the Department of Oral and Maxillofacial Surgery at Farooqa Dental College, Mysore, under Rajiv Gandhi University of Health Sciences, where he teaches the postgraduate students and trainees. Sir is also the Center Director, DCKH Project Mysore, and is the head of department for Center of Cleft Services at St. Joseph Hospital, Mysore. He has also been nominated for the leading health professionals of the world in the year 2013 by the International Biographical Center, United Kingdom. Sir has also been actively involved in research in the field of craniofacial surgery, nasal cartilage, and stem cells. He also trains fellows and surgeons in India as well as abroad. I welcome you, sir, on behalf of our institution.
Thank you very much.
Sir. So now I request you to enlighten us on today's lecture. Our first lecture's topic will be on understanding the cleft lip and palate deformity, philosophies of management. Over to you, sir.
Thank you very much. At the outset, we would like to thank Dr. Pramod Krishna, who is my good friend, for giving us an opportunity to share our experience. And today, we would like to just showcase, because cleft lip and palate is a huge topic. In one day, it is difficult to concise the whole thing. So what we thought is to, for the benefit of postgraduates, we wanted to showcase the aspects of cleft lip and palate, basically the concepts, and then multidisciplinary management, and then what it called as comprehensive cleft care. So with this gist, I hope majority of the people will get influenced and they look at cleft as their mainstream of activity. Okay. So today we will be now. Can I share my screen now?
Yes, sir, you can, sir. Please.
Is it the screen is shared?
Yes, sir, the screen is visible, sir.
Okay. So as I told, the comprehensive cleft care is looking the cleft lip and palate and associated deformities in a comprehensive way with the eyes of multidisciplinary team. That means to say it is the surgeon, and there's a huge lot of team that you will be getting to know as we go along. So preliminarily, to understand cleft lip and palate, cleft lip and palate, we all know that this is the second most commonest birth deformity and the first commonest deformity of the face. And cleft lip and palate is in the world, if we take that as in the degree of difficulties, it is considered to be one of the most difficult surgery to perform because it involves a lot of thinking, creativity, and craftsmanship. That's why it is called as craftsmanship. The cleft word is always associated with craftsmanship because that indicates a lot of ideologies, planning, and then execution in a nice way. And then today, as I told, that the cleft lip and palate in India, if we see, according to the statistics, each year we have roughly about 40,000 cleft kids being born. So that is a huge amount of cleft patients where a good center has to be treated. And we in India have very few comprehensive care cleft centers, which are really doing well, but still the number of comprehensive cleft centers are still limited for all the patients, all the cleft patients in the whole India. And to tell about the statistics, if we take today, by the end of this our knowledge sharing session on cleft lip and palate, there will be roughly about 14 new kids or the new cleft children. They'll be waiting for some of you people who get interested in cleft lip and palate, who gets influenced. In case if you come across, then you will be handling those kids. So that is the incidence of cleft birth in India. So that means to say in 3 hours, if we are sitting and sharing knowledge, there will be another 15 kids who will be needing the surgery or the complete treatment. So that's the statistic. Now going to cleft lip and palate per se, this is the presentation. Usually we will go according to the planned sessions. The first session is understanding the primary lip and palate anatomy, the concepts. Second will be multidisciplinary approach. Secondary deformities, multidisciplinary approach. Then comprehensive cleft care and craniofacial. So first, to understand what is cleft lip and palate, before going to the concepts as such, for the benefit of postgraduates, I want you to have a very brief introduction about embryology. Dr. Namita will tell you about the embryology. Then I'll take up the clinical aspects and then concepts.
Good morning, everybody. So we see that at the end of the fourth embryonic week, facial prominences of neural crestal origin appear from the first pair of the pharyngeal arches. While the maxillary prominences are found laterally, mandibular prominence is found inferiorly. The frontonasal prominence forms the upper border of the stomodium or the primitive mouth. There are local surface ectodermal thickenings which occur on either side of the frontonasal process called as the nasal placodes. During the fifth week, these placodes invaginate inside to form the nasal pits, creating a ridge of tissue around the pit called the lateral nasal prominence laterally and the medial nasal process medially. Over the sixth and the seventh week, the paired maxillary prominences start growing medially towards the paired medial nasal prominences. Fusion of the paired M and P and the maxillary prominence occurs, thereby forming the upper lip. The medial nasal prominence fuse to form the philtrum, the medial upper lip, the nasal tip, and the columella. The maxillary prominences from the form the lateral aspect of the upper lip, and the lateral nasal prominence form the nose, and it's not involved in the formation of the upper lip. Finally, the nose is formed from 5 facial prominences. The bridge is formed from the frontonasal process. The tip and the columella is formed by fusion of the medial nasal prominences, and the nasal ala is formed by the lateral nasal prominences. Next, palatogenesis begins at the end of the 5th week and complete fusion occurs by 12 weeks of the development process. As the maxillary prominences grow, they push the medial nasal prominences medially. They fuse not only at the surface but also at a deeper level. This fusion forms the intermaxillary segment or the primary palate. It includes the central maxillary alveolar arch that houses the 4 incisor teeth and the hard palate anterior to the incisive foramen. Once the primary palate is completely developed, the secondary palate begins to develop. The secondary palate makes up the major portion of the palate. It is formed from the palatine shells, which are 2 outgrowths of the maxillary prominence. In the 6th week of embryonic development, the palatine shells are directed obliquely downward on either side of the tongue. However, by 7th week, the palatine shells migrate infero-medial to lie horizontally above the tongue. It is in this horizontal position that the palatine shells fuse in the midline to form the secondary palate. Palatal fusion occurs from anterior to posterior, beginning at the incisive foramen at 8 weeks of gestation and reaches completion by 12th week with uvular fusion. Now, the degree of clefting is a consequence of the point in the fetal development at which this process of fusion was interrupted. The development of lip starts from 4th week of intrauterine life and continues to 8th week, and the development of palate starts from 5th to 12th week. In these weeks, if there is any interruption in the process of fusion, we can see a cleft. For example, here in this figure B, which is an axial cross section, we see that the maxillary process is fusing with the medial nasal process with the residual groove that is closing and filling up on the right side. However, it is not filling up on the left side. This is followed by dehiscence of the intervening tissue in the groove. In the bottom picture on figure H, we see that the right maxillary process has fused with the medial nasal process to form the right half of the upper lip. However, a cleft is evident on the left side due to non-fusion of the medial nasal process and the maxillary process. We see an incidence of cleft lip and palate of 1 in 750 births and in cleft palate around 2 in 10,000 births. As Sir said, a child is born with a cleft every 2 minutes according to statistics by World Health Organization. We see that there is both genetic and environmental factors that contribute to cleft lip and palate. We often see that in monozygotic twins, up to 40 to 60% concordance is present in cleft. However, lack of 100% concordance suggests that genetics alone does not determine orofacial clefts. Clefts of the primary palate, those that involve with or without the remaining palate, arise from a different mechanism than do clefts that involve only the secondary palate. Currently, we see that about 70% of patients with cleft lip palate are non-syndromic and sporadic, whereas up to 50% of the patients with cleft palate are syndromic. Several teratogens have also been implicated in cleft development, including alcohol use, tobacco smoke, phenytoin, retinoic acid. It's also been seen that multivitamin supplements have been shown to lower the risk of cleft lip palate and possibly isolate cleft palate. Now I call in Manu sir again to explain the anatomy of the cleft lip.
Thank you. So, to summarize, we are not going to the classification and nomenclature and all those things, because those are very, you can read it over the textbook. Today, what we want to showcase is understanding the concept. So I'll directly go to the concepts as such. Embryology, I wanted to really emphasize on that because the concept depends on the embryology. That means the nasal processes. Embryologically, if we see the theories about cleft, what they say is one is the fusion of process, the second one is mesodermal migration, and the third is combination. So the whole concept depends on this. There is a fusion of processes which fails, and then one says that there is a mesodermal migration, and then it stops by some difficulties or the deformities, and then the combination. Now, with that, we will go to the anatomy. So now, before going to the cleft anatomy, we should definitely know about the normal anatomy of lip and nose. As the evolution took place, in 1980s, there were people who were concentrating on the lip architecture as such, and then slowly, as we grew along, as the technology or the evolution of surgery happened, the attention from lip, because after that, many people could attain a lip symmetry nice, and then the attention moved towards the nose. That's how the evolution takes place. So now, if we look at the primary lip and nose as such, from the top, always we come from the top. So we have centrally based columella and then ala. So there is a difference between alar position and columellar position. If you see from caudal, that means to say that if the columella stops here, the ala on the both sides has to be about 1 millimeter behind. That is posterior. So that is aesthetic in nature. Then from the columella, there runs two ridges called as this philtral ridge or philtral column. And then in the middle, we have philtral dimple. Then we have Cupid's bow. The Cupid's bow has got white roll as described by Gillies. Then we have mucosa or the vermilia. In that we have wet mucosa and then dry mucosa. The dry mucosa defines the lip junction, and then we have wet mucosa where we start the oral mucosa, and then we have commissure. So the upper lip has got a classic something called a tubercle in the middle. So whenever either you are in aesthetic field or in the cleft field, you have to have an idea of the lip anatomy, how it goes from lateral to central, from linear. If you see in the I hope you can see the cursor. From the corner, if you see it grows linearly, then there is a scalloping, then you have a tubercle, and then again there is a mirroring of the other side. It may not be mirroring always. There will be definitely asymmetry a little bit here and there, but this is what is a classic normal lip and nose complex looks like. If we see from the anatomical side, the muscles, you are all postgraduates, I need not go in depth of it. We have most of the muscles which are from the modulus running as one splinter. From the top, you have alacinaceae and the nasal muscles, and the whole complex acts as one unit. That's what we need to understand. And in cleft, how it differs, I'll explain you now. This is the cleft anatomy. So how we saw from top to bottom, we will look the same thing from top to bottom. So if we see the nose, the first thing what it says is there is a normal alar shape of the non-cleft nostril. Next is there is a flattened cleft nostril. Then the attention goes to the septum, which is deviated to the non-cleft side. And then it is not that simple. The alar cartilage is scalloped. So this is the fundamental anatomy what we need to understand to recreate. There is a normal ala, septal deviation, flattened column, the ala on the left side, or there is a scalloping. That's why we do open kilorad. These are the fundamentals. Okay? Then it is not that simple. We have alar base position. So alar base position differs in majority of the cases. If it is at the same level, it makes us easy to do the surgery. As you see in this case, there is a big, huge difference between alar position from the left to non-left side. So if we come to the anatomy of the muscles, the orbicularis oris muscle, which supposed to unite in the middle, takes a diversion and it goes to get attached in the cleft side ala. In the non-cleft side, it goes and attaches to the anternasal spine, which is deviated. So this we have to understand. Two more things we need to understand is the columella is deviated and then there is anternasal spine. If we see closely a cleft baby, there is a lump which happens in the cleft side. Okay, so the muscles, before it gets united, it becomes a ball kind of thing, and then it becomes a lump. And then, but on the other side, even if it is a greater segment, as it goes along, the muscle gets really thin. So this is the major discrepancy what we find in terms of muscle recreation. So we'll go directly to the concept now. For the brief, we follow thumb rule. It's rule of 10, that is 10 pounds, 10 hemogram, 10 weeks, and counts less than 10,000. Then we can go to the cleft lip. The goals of the cleft surgeries are the maximum aesthetics of lip and nose has to happen. There has to be a facility for feeding, a reconstruction of lip mechanism, nasal cavities to be arranged, and then it should facilitate the normal facial skeleton. So to understand the concept, if anybody wants to just have a look at it or read about it, they definitely should read about Millard's Cleft Craft. It is a very fantastic textbook. I cannot call it as a textbook, it is kind of a novel. If somebody reads to it, it is like a story. It talks about how the cleft evolution happened, surgeries from 18th century till Millard's era, and then after that the new editions are not there, so it stops there. But if we understand cleft, it depends, the treatment lip, especially unilateral lip, mainly depends on three philosophies. One is rotation advancement, next is triangular, and then functional repair. So before Millard's era, there was only paring. That means to say margin was removed and then direct closure was happening. So that was the first, in the Chinese time it was there. Even if it started 1.5 centuries before Christ, there was cleft surgeries happening. And then the evolution started. Then there were people who are not so keen on aesthetics. They were just closing it straight. So that was called as straight line closure. Then the era started. Then they were looking at, still it is not so aesthetic. So what can be improved? Then many people have contributed, starting from Gillies and everybody concepts. But the person who looked at the upper lip as a whole was Lemicher. Okay, if somebody can read about Lemicher's contribution, Lemicher was the first person who established a Cupid's bow. So the Cupid's bow established, but the main drawback of Lemicher was, I am not putting many figures because it will be a lot of confusion. That's why I am putting only a few. I am talking a few figures of only these primary concepts I am putting. Lemicher, he borrowed the major half of Cupid's bow from the non-cleft side. That was the fundamental wrong what he went wrong, because the major content has to be drawn from the greater segment, not from the lesser segment. But he was the first person who conceptualized something called as Cupid's bow. Then came In 1950s, it was Millard, and then the other contemporaries were triangular flap. Okay? So triangular flap also has Tennyson and Randall. They conceptualized something called a Stupid's bow, but they were a non-anatomical. So I'll go into each and then I'll tell. So for the benefit of postgraduates, what you have to understand is not to go on the basis of techniques. Okay, techniques changes. Cleft is such an aspect. If I am doing cleft for some 10 years or 15 years or 20 years, I will have my own technique. There will be modifications each day because one incision goes here and there will be a modification. But the fundamental concepts remains the same. Everything is based on one principle: rotation advancement or triangular, that is Z plasty, or functional repair. These are the three fundamental concepts. On that, the techniques differ. So you have to understand this. So one fine day, what has happened was Millard's, when he was having a tough time conceptualizing what was before Cupid's bow, he was in his room looking at all the photos to how to recreate the Cupid's bow and where the missing component is. Before this idea, all were thinking it is the tissues are missing, and only maximum what you can do is a straight line closure. And there was a consensus in the before 1950s that the cleft means tissues are missing. That is what the conception was. So one day he was looking at all the photos, and in his immediately after training period, and then he slept off while looking at the photos in that night. Then suddenly, after an hour or so, he got up, and then he saw that one photo was tilted, and he saw in a different angle. Suddenly, he realized that all the component what he was looking is there. It is just there. So what made him to think like that is, if you see this photo in this angle, you think it is a missing Cupid's bow. That is the 2/3 of the Cupid's bow. This is the Cupid's bow from here till here. It is the 2/3. And then suddenly, if the photo flips like this, so you have the whole length of Cupid's bow there. So it is not missing. It is there. It is just that it is not in a position. We need to take it to a downward position and then get the left side and make a normal Cupid's bow. This was a kind of eureka moment for him. And then he was still not sure. He got his friends, and then they drew a lot of diagrams, and then they thought they can try to do one surgery. And then he was posted in US Army, and then he went ahead and then did a surgery. That was the changing era in left treatment as such. So he introduced this concept of rotational advancement technique in 1955. That was the idea of how it happened. And then the major theory behind this is rotational advancement technique. It relies on, it is like cut as you go strategy, and it allows continuous modification. On this principle, there are a lot of people who have come and they have told that no, I've changed Millard's. No, Millard's principle remains the same. The techniques, yes, there are small techniques, tweaks here and there they can do it. So I hope I can play the video.
Demonstrated in this animation is a variation of the Millard rotation advancement repair to close a left complete cleft lip. The Millard repair is the most common technique for cleft lip closure. Prior to making the first incision, the lip is first marked to properly plan incision placement. Points 1 are the edge of the lip commissure on both sides. Points 2 and 4 mark the lateral edges of the Cupid's bow.
Okay. If I got to know that there was some hiccups with the video, I'm audible, right?
Yes, sir, you're audible, sir.
So this is what we usually mark during the surgery. Few things what we have to understand is, as I told, the orientation of the muscles on the non-cleft side and the cleft side, and then the cartilage. So in our center, what we do is something called open rhinoplasty, which is done very less in the world. We address lip and nose complex altogether. With Millard's lip technique, we open up the nose and we do the alar cartilage repositioning, and then we do the nasal architecture and as well as lip architecture. That is the fundamental difference between our center and where it is only the lip has been done. And this is what is the alar cartilage position, which is held by the adjacent fibrofatty tissue. The septum is deviated. This is the flatness, and this is the normal cartilage on the other side. So as I told, this is the primary rhinoplasty, which we are doing a study, and we are surely it will be published in a short time. So it is a musculo-aponeurotic cartilaginous complex will be placed in a proper position with anatomical physiological orientation by direct visualization, and then the cartilaginous structure will be done by either semi-open or open position. It is little difficult to understand as a postgraduate, or if somebody who is there in the viewers who are already doing cleft, they might get this definition. So how the concept is originated is through histological, anatomical, and anatomical backgrounds they have taken, and we have done this. So histologically, if we see, the cleft is denoted by extrinsic theory and the intrinsic theory, the severity of the cleft. We got to know now from the orientation of muscles, cartilage, and position, but you have seen the photos. Some people have a lesser degree, some kids have a higher degree of deformity. That is explained by these two theories. The extrinsic theory, what it says is, the tissues are there, but it is malpositioned. So because of that malpositioning, there is a big changeover of the deformity. The intrinsic theory says no, that is not the case. The intrinsic theory says there is some inherent deformity. That's why there is a discrepancy between presentations of some cases. So what we thought is, let us do a study by understanding what the extrinsic theory influences or intrinsic theory influences. So we took cartilages and fibrofatty tissue on the cleft and non-cleft side. We studied, but in our study, it showed that there is definite inherent problem with the cleft cartilage, also cleft aponeurotic these tissues. So all those things is not required, but ultimately this is what we want to establish in a worm's eye view. So understanding that if we release the cartilages in the proper way, we can establish this kind of triangular nose and also lip. So this is the fundamental of the technique. So this is, with that we have come up with a classification of the cleft nasal deformities, and then it goes mild, moderate, severe, and what has to be done. So that so much is not required. So this is just before, as I explained, this is the attachment in the lower segment, that is the cleft side, we need to understand. And this is of the attachment on the non-cleft side, the greater segment. And the position of this alveolar base influences alar position at the final stem. In CT scan, if you see this, here it is rounded shape, the margin, and it is at the straight line. So this is where the alar cartilage is attached, and we need to free it. Okay. This is something called as surgery before surgery concept. That means to say that before doing surgery, you just pull up the tissues and see. If you don't release properly, don't rotate properly, and then don't enough do the proper alar dissection, you will end up something like this. Okay, the same case with open killer rhinoplasty, how it will be, we will show you. So this was the child, and this is how she is after doing proper lip and nose together, and this is still after she grows. So the results are still maintained. And this is another child with the open killer rhinoplasty technique. The same girl who is grown now. And then the another child, which the triangle I showed to the nose. So the disadvantages of Millards. So I hope the Millards concept is conveyed to you. If you have any doubts on Millards concept, at the end of this session, you can note down and you can ask me any questions on that. We will try to clarify. So the experience, it requires an experience and artistry, because it is not measurement based. It is purely based on geometry. That is the rotation. This mainly depends on surgeon's awareness and judgment. Okay, and a vertical scar. We all know, we are all surgeons, and majority of the people also have some amount of suturing done in their different departments. Any linear scar will contract. So this is the fundamental problem with Millards. Additionally, this vertical scar occupies the filtral column and then subjected to wound contracture. Sometimes there is excessive webbing over the nostril. So that can be compensated by doing open killer rhinoplasty. So with this, there is one more person called Dr. Fisher. He has modified this technique with a geometrical measurements. It was published in 2005. You can see the article by Dr. Fisher. Dr. Fisher's technique of, it is called as anatomical base, this sub-anatomical unit technique or something like that. So he takes proper measurements. It is an improvisation over this proper measurements, and with that you can, what the article says, you can establish a proposed or predictable kind of results. Okay, so just to slow down the variations. Okay, so the next is Tennyson-Randall technique, that is the triangular flap technique. So the fundamental was rotation advancement, where the lip was rotated and the other side was advanced. So that is the rotation advancement. Now triangle, that is Tennyson-Randall technique. At the same time, in the other one was there was two things were got propagated. One was triangular flap was getting propagated, and was rotation advancement was propagated. So the Tennyson a little early in 1952, 1951 was Millards. 1952, the second group was by Tennyson. He thought that the Cupid's boy is there, limit shares technique. He improvised and he gave a proper cut, and he released this here. So this was the cut he gave, and he released the complete grid segment or the Cupid's bow down, and he made sure that he got the Cupid's bow or the lip anatomy. But the only problem was the release was very at a lower level, not at the higher level. So the scar, the aesthetics, all were compromised. And on the other side, there was tissues which were actually they could not preserve much of tissues, and the nose was, there was no scope for to improvise the nose in this technique. So this was the technique of triangular lip. So this is how the triangular lip in a diagrammatical representation look like. If you cut, it will drop down. At the same time, you same measurement. If you give a back cut here, the same projection will go and sit there with the 9 and 10. 9 and 11 will be the same. So 10 and 5 in this gap, that is the triangle flap, will go and sit inside exactly into the triangle defect. So this is the concept of triangular flap. So we will just see. I hope this surface runs. That's how the triangle closure will look like. So there was a lot of debate over which philosophy is good or which technique is good. So in the field of cleft, being with at least more than 15 years, what I can say is the triangular technique has got, it's technically it is easy to perform, but there is a non-anatomical scar, and it is visible. And at this era, I think any kid or any parents wouldn't accept which is non-anatomical scar. If it is visible, it is very difficult to correct at a later stage. And where the Millard's techniques gives a scar over the filtral line exactly mimicking the opposite side filtral ridge. So that gives an added advantage of having the scar in a neutral position or the anatomical position. The classic Millard had explained that there is a alar incision, but that has been taken out very long. Nobody at this time do the alar release. There are modifications on the incision side. I'm not going too detail on the modifications on the technique because that's a totally different topic. I'm just trying to explain the concepts. So there are improvisations, and Millard's philosophy stays for a longer time. There will be modifications, but Millard's philosophy stays for longer. One more philosophy, what we need to understand is something called Dillard's functional philosophy of the technique. Dillard was a surgeon who believed that the cleft nasal anatomy requires a drastic changeover. That means to say the dissection has to be going till the infraorbital margin and then subperiosteal. There is an aggressive removal, the elevation of nasolabial complex, taking it to midline and then doing the reconstruction, and also the reconstruction has to be done with 3 rings of lip muscles. Distribute the lip rings, and then orbicularis, or if we see, try to understand the anatomy, we get the rings. So he actually proposes to recreate the exact anatomy. The advantage we get easy recreation of cleft on the non-cleft side. So that is what is Dillard's philosophy. Most of the surgeons do believe that aggressive reflection of the cleft side will give a more aesthetic look. But in our center, we do supraperiosteal dissection, and we are still happy to get a good lip and nose anatomy. That I'll tell you later in the controversies. So this article tells about Millard's and then Dillard's functional relationship. All the article links I can share. This will be it will be downloaded, and Dr. Pramod, I can share. Dr. Pramod, anybody who is interested can get through the article, and these are the key articles in the field of cleft lip and palate. If you can have this as a sum up, you can refer it anytime. Okay. Then we will go to bilateral. The fundamental difference between bilateral to unilateral is both sides of the cleft is affected. So similarly, if we come from top to down, we have the nose, which is unaffected by growth. The nose will be growing. The prolabium will be growing because the septum is attached to the prolabium and it will be growing. The fundamental difference is the effect of lesser segments. In the unilateral, it was only the one segment was affected, but in the bilateral, it is 2 segments which will get affected, and it will be really placed at the back. So if we see this, we see it is a very difficult lip to correct. The prolabium is very much ahead. The premaxilla whole complex is very much ahead of both the lesser segment. If I do the surgery immediate at this stage, there is a chance of gaping, there is a chance of necrosis, and there is a chance of even premaxilla being lost. So many things can happen in this case. Now we have nasoalveolar molding, which is helping a lot in our center. We will showcase when we enter into multidisciplinary approach. But at this time, yes, we had to do the primary lip closure. So this is the most commonest is called straight line closure. We have a small modification called Black's modification where we keep the mucosa, a very little mucosa on the vermilion preserve, and then we do the lip. So premaxillary area, the prolabium is elevated, and then again the mucosa has been pared, muscles will be taken into dissected nicely, alar position will be elevated, and then we will get a prolabium like this, and we will have a primary closure. But again, here the tubercle gives the form aesthetics. So we have to understand that we have to have a lot of tissue to recreate the tubercle. So this is how the the Black's modification and vermilion recreation looks like. This is the primary lip. In this case, it is not so wide. So this is the primary lip, the prolabium and the lesser segment. But in this also you can see the uneven thickness of the muscles here and there. The height was a question to recreate how it was difficult. And then he is a not so young child, so still the pliability of the tissues will be a question we need to address. And then with proper dissection, proper doing, we get a good nasolabial complex, a good vermilion, a good cupid. Okay. So one more child who had a very premaxillary at a higher level, and then we were able to do the closure. In this case, why I wanted to show you was he didn't. He was in market actually. He was as a worker. He was working. He never wanted to get his lip correction done because their parents believed that because of his cleft, their business was growing more. So they didn't wanted to get the surgery done. But somehow the grandmother wanted to have this child corrected, but the parents never wanted because they believed that the cleft of this child is held a fortune for them. So that kind of misbeliefs also will be there in the society. So I hope the lip concepts are clear. The animation videos, I don't know whether it was clear, but we have tried to show the lip components, clarifying about the anatomy, the technique, and then the creation of the whole nasolabial complex. And then if Dr. Pramod can tell, we need to have a break, or I can finish the palette. I can go to the palette. Anybody from the, I can continue?
Yes, sir.
I can continue with the palette?
Yes, sir.
The 45 minutes you had told, so it's okay, I'll continue.
Hello.
Yes, yes.
Yeah, Manu. Should we take some questions now, or shall we take after all the presentation?
If we can finish primary lip and palette, and then questions can be taken.
Yes, I think then you can go ahead with palette, I guess. Yeah.
Okay.
Yeah.
So, understanding cleft palate. So, what are the goals of cleft palate? Is to produce anatomical closure of the defect, to create an apparatus to produce a normal speech, to minimize the maxillary growth disturbances. That all things can be achieved if we properly do the surgery at the correct time. So the principles remains for palatoplasty are to close the defect, correct the abnormally inserted muscles, recreation of palatine sling, tension-free repair, then 2-layer repair of the hard palate and 3-layer repair of the soft palate. Again, rule of 10 for cleft palate. The child weighs 10 kgs, hemoglobin will be 10. The month ideally it should be 10 and above. and then the child white blood counts less than 10. So this is the cleft nasal anatomy, the cleft palatal anatomy. If you see, uh, this is the greater segment and this is the lesser segment. This is the omarine bone. Okay, this is the omarine bone will be attached to the greater segment always. This omarine bone has a lot of tissues, so that tissues will be easy to have a nasal layer further. One point what we need to understand is the greater palatine artery. Okay, that is the principal artery which gives blood supply to the mucoperiosteal layer of palatal layers. It will be usually between second and first molar, and then it will be about 5 to 7 millimeters from the gingival margin. So that is the normal placement. And then when we give an incision, usually I do first the midline incision and then I go to the lateral incision. So the midline incision will be across the margins, crossing over the junction of omarine bone and the oral layer, and then it goes along the anterior point, that is the anterior alveolus. And then here the pterygoid hamulus should be felt, and then incision has to be given. And then along the gingival margin, just 1 millimeter you can give, and then you can raise the gingival flap. Only thing what we need to really concentrate here is this C-shaped defect. This is the point where it is very, very difficult to release the nasal layer. This is where the maximum fistulas happens. The fistulas can happen at the nasal-alveolar complex area, mid-palatal area, and the posterior, but this is the commonest. So before going to the technique, the understanding the normal palatal muscles is we have this aponeurosis, which will be mainly by levator palati muscle and then fibers of tensor palati muscle. This makes palatine aponeurosis, which will be augmented by superior constrictor and then this palatopharyngeus, the few fibers. All those things will raise the soft palate to the posterior wall of the pharynx. That's how the complex closes, sounds come, and also helps in deglutition. And then, as I told, this is the palatal foramen where it will be emergence of the palatine artery. And then few relation in the speech when it comes, they'll tell about the proper relation of auditory canal and about insertion of the tensor muscle. It acts on opening of auditory tube. That gives, in case if because of the cleft palate association with the palatine tympanic muscle and then auditory canal, if there is a blockage or if there is inadequate opening, there will be always discharge, ear discharge, and there will be subsequent ear infection, and then there will be could be loss of hearing. So in our center, during the palatal surgery, in case if it is required, our ENT colleague also will be present and he'll do the grommet insertion in case if it mandates at the child. So we will talk more about multidisciplinary approach at a later stage. So this is the in case of a primary bilateral incomplete cleft palate, you can see the anatomy. If it goes, there is no union in between. So what it happens is both the muscles, tensor and levator, they go and attach to the posterior nasal spine all along the margin and a little ahead from the posterior margin of postnasal spine. So the key anatomy in the palatal dissection is the postnasal spine. Identify that and release all the muscles which are attached to the postnasal spine. So coming on to the again the commonest of the commonest techniques are Von Langenbach, Wadekilner, Bardash, and Furlos. So Von Langenbach is technique is the incision will be given all along the lateral margin and the medial margin, but there is no cut in the anterior margin. So this is the Von Langenbach, very way back he had proposed, and then two-layer closure was done. This was a very preliminary kind of addressing the cleft palate closure. And then comes water kilner, where they thought it is a pushback, which will help in getting the palatal complex into the pharynx. So the anterior modification is there is a sharp 45-degree turn, curve back, and then the whole complex will be pushed back, and the muscles, they concentrated more on the muscles, and then they could establish a long length of soft palate. If you can see this diagram, you can see that there was a raw area what they had kept, and there is a single layer. The only disadvantage in this is there is a high chance of fistula or the opening of palatal layers. So Bardak's two flap, this is what we follow in our center. So Bardak palatoplasty is combination of both the things what I just spoke, pushback and then von Langenback, and then Summerland's muscle resection I'll tell you. So with this technique, we can get a good closure to flap palatoplasty. The incision and photos I'll explain. So as I had shown, so the anterior incision goes along the margin to the alveolus area and then along the pterygoid hamulus. So this is the releasing incision. These are the two flaps. I hope the diagram is clear. This is the nasal layer closure. And what you can see is from the nasal layer to the oral layer, this is the muzzle. Okay. Again, that muzzle will be taken into single layers, and then we will close the muzzle as an independent layer, and then we can get a closure. So you will be amazed to see that even with this gap, we are able to close the lateral margins. Only a few millimeters of lateral gap is there. Otherwise, we have got a good closure. That is because the palatal tissues or the palatal layer, it comes down. So the lateral gap will becomes less. Okay, and then this kind of suturing, what I want to emphasize on suturing a bit in here is all the oral layers, whenever we do where there is a tension, always we have to have a mattress closure. Okay. So the mattress closure augmented with an interrupted closure will give us a long, a good rate of success. In our center, I can say in the last 10 years, we have less than 1% of fistula rate, and also fistula rate could be with multiple reasons. When we talk about fistula, I'll tell about that. Okay. And then few different presentations of lip and palate. Palate. It is the bilateral incomplete and bilateral complete. So in the bilateral complete, we have premaxilla, which will be a disturbance. So you have to borrow the premaxillary tissues from top, and then you have to rotate it and make a palatal closure. Okay. So this is the Furlow's technique. So I hope this at least runs. So I think the videos are a little difficult with Zoom. So this is how the closure will look like. I'll explain myself. This concept is double Z plastic. That means to say there are two Zs, one in the oral layer and one in the nasal layer. This concept is by from Furlow's. It was in 1978. It gained a lot of popularity because it produced a lot of good speech in terms of results, and in terms of lengthening, we had a lot of good cases where there was established measured length. But the problem is it cannot be done in wide cases. It has to be done in a narrow cases, and then again it's a very technically sensitive surgery. you have to have a thorough knowledge of how the anatomy goes. Okay, so oral layer, what can be done? Vertical incision at the margin, and then an horizontal or the angled incision at the anterior region, which has muzzle. Okay, this can have muzzle, and then this can one flap will have muzzle and one flap will have only mucosa. When the flaps are elevated, below that there will be again flaps with one side will be muzzle and one side will be mucosa. So the oral layer which has already muzzle will have mucosa, and oral layer which has only mucosa will have muzzle. So exactly at the bottom of that, we have to transect, and that has to be reoriented so that the muzzle comes posteriorly and the mucosa comes anteriorly. That is the only change you have to do. So if you see the incision, the linear incisions becomes horizontal incision. That is the basic concept of a cleft plastic. Okay, so the linear incisions becomes horizontal, and then the muzzle will be oriented posteriorly in a horizontal fashion. And the oral layer again, which had the muzzle, will be taken it as posterior. So you can see the sling will be established at the posterior end, and it will be pushed back. So that is the concept of Furlow's technique. Very difficult to do, not to do, but to understand. When you open up all the four flaps, if you are not experienced, it is really tough to get to know what the flaps goes where. But as you go along, as you do along, this gives a very good results with cleft speech, in terms of speech. In our center, we don't do much in the primary stage, but for the secondary cases, yes, Furlow's has been routinely carried out. So the advantages is repositioning of musculature into more anatomical location, lengthening of palate and improved speech. And then the concept of intervelar veloplasty. In the two-flap palatoplasty, this is what we at our center we follow. Intervelar veloplasty defines that the third layer, that the muzzle layer will be elevated and then reoriented in a most posterior place. So I'll show you with the diagrams. So this is the normal and this is the cleft muzzle which is present. So there is a classification, but ideally what you need to identify and establish is type 3. So in type 0, it will be closed as it is. In type 1, the lateral elements are closed. Type 2, only the anterior tip will be closed. Type 3, it won't be pushed backwards, but it will be closed at the middle, but the muzzles will be elevated and closed. If we can establish type 3 muzzle recreation, this will be the best for success and as well as deglutition, all the functions, speech, deglutition, phonation, everything. So this is what we anticipate or try to establish. The whole muzzle length will be elevated, cut from the PNS, postnasal spine, postnasal border, taken it completely, make it as an skeletonize it, individual layer, and then rotate it and push it as posterior as possible. Okay. So Summerlands is the one who really propagated about intervelar veloplasty, and then next. So according to him, the levator and the tensorineural palatine muscles also has to be really separated, and then the closure will be done under microscope and individual muscles. With the microscope, we can make a cylindrical loop of levator muscles separated and tensorineural palatine separated. But in our setup, we don't use microscope. Loops are being commonly used, but to establish the muzzle contribution or the muzzle attention is taken more in the now the cleft era. The aesthetics were the concern before 1970s to 80s. Now, from 2000 onwards, we are really concentrating on speech. It is not just the patient should look good, patient should speak good. Then only he will be incorporated into the society for doing something on its own. So the speech is being taken as a very primary area of research as well as technique improvement. And then in our center, we are able to do a good speech reproduction with surgery and as well as combined with speech therapy. So cleft palate variations, our good friend Dr. Karun Agarwal's article is there. You can go through that. It will be a lot of knowledge with that. So can we, you want us to continue with this alveolar bone grafting? It will be primaries will be done.
I think, yeah, you can finish with this and then we can go for some discussion.
So alveolar bone grafting, Dr. Surabhi will talk about it. It is just a 5-10 minutes of discussion, and then I can take all the questions, whatever there for primary.
Thank you, sir. So to continue with alveolar bone grafting, the objectives of alveolar bone grafting mainly to stabilize the segment, and it also gives a bony base for teeth to erupt. Unites the maxilla to better withstand the occlusal forces. It improves oral hygiene. Nasal secretions can be prevented from draining into the mouth. It improves nasal symmetry. It also improves the social acceptance. So alveolar bone grafting can be divided into primary and secondary bone grafting. Primary bone grafting is usually done with the first 2 years of life, and secondary bone grafting again divided into early, intermediate, and late. So primary bone grafting was popular in the year 1950 to 1960, which was done along with the maxillary orthopedics. Rib graft was commonly used. The bone site was rib graft, and then this was not popularized. It is not followed regularly because it affects the maxillary growth. The main disadvantage of this primary bone grafting is it affects the maxillary growth and the nasolabial appearance. It may further require bone grafting in the early childhood because of insufficient alveolar bulk. Coming to secondary alveolar bone grafting, it is usually done between the age of 5 to 6 years, that is before the eruption of lateral incisors. And late secondary bone grafting is done after the eruption of permanent canine, that is during the adolescence. It is sometimes combined with orthognathic surgery. Coming to surgical management, the ideal time for bone grafting is between 9 to 11 years of age, that is before the eruption of canine. The best source of bone is from the anterior iliac crest, the rib, the tibia, the cranium, or the mandible. In this picture, we can see a large alveolar defect, a large alveolar cleft with the occlusal view preoperative. You can see the bone defect, and the second picture here you can see the post-surgical closure. So the relation between bone grafting and orthodontics. So as a general rule, it is said that tooth movement is improved when it is when the tooth movement is that is orthodontics is done after the alveolar bone grafting. That is, tooth movement should be initiated immediately after grafting. So coming to the surgical technique, usually the anterior iliac crest, the bone is harvested. The first picture you can see the incision is placed around 1 centimeter inferior to the anterior superior iliac crest, and the dissection is carried out to the skin, the subcutaneous tissue, and the scarpa's fascia. If this kind of dissection is carried out, it prevents injury to the lateral femoral cutaneous nerve, the iliohypogastric, and the subcutaneous nerve. Once the iliac crest is exposed, the graft can be harvested by different techniques. That is, it can be harvested through trapdoor technique or Tessier's technique. There are some complications which can occur during the iliac bone grafting, which includes infection, hematoma, gait disturbance, abdominal hernia, chronic pain, and cosmetic deformity. Thank you.
Yeah, we are good to go to take any questions of the primary
Yeah. Uh, Yeah, it was a very good presentation, Manu. Like I was very impressed when Millard got a eureka moment of tilting the picture to see the cupids go. Yeah, I think we have our eureka moments every time. Uh, that's thing. And there is one question which happens to be from my postgraduate itself. Is there any difference in the maxillary growth? Like there is between subperiosteal or supraperiosteal dissection when it comes to cleft surgery. Like we see the patient, we do the cleft lip palate surgery. We see the patient after 10 years with severe maxillary hypoplasia. So is there a way to get away with it?
Uh, According to the literature, there is no difference as such.
Okay.
There is a long study, but there is no statistical difference between either subperiosteal or supraperiosteal dissection. And if we see the lip, it is the most in the anterior part, but the most maxillary deficiency happens because of the palate or the palatal mucoperiosteal layer elevation. But that cannot be it has to be done. So there is no way that we can't escape from that.
Mm.
But for that, there are few things which we can think of. That's a very good question. So that leads to another. I wanted to talk to in the last, but I will talk now. For the palate, there is something called staging. In Europe, there is one group of in the Basel. What they do is they do lip and palate together. That is called as hole-in-one technique. Only in Poland, Basel, these are the only two places where they do lip and palate all together at 3 months of time. And also they do even for the adult. For us, the presentation of the child is if we get a child at the very early age, we can do lip closure. Few schools of thoughts are during the lip closure, if the nasal layer has to be closed to the most posterior aspect. So we are almost getting the hard palate together. So there is no when we do the palate, there is no reflection of periosteal. So aggressive reflection is not required. The narrow space will happen, and then the growth will be improved. The second thing is staging. So few groups are there. Those are Schwackendick, the one surgeon who was very fascinated by staging the palate. He used to do palate, uh, soft palate during the time of lip surgery, and then leave the patient as such, and then do the palate surgery after 4 or 5 years. According to his group, there is a lot of advantage because the growth disturbance is not happening because we are not elevating the nasal mucoperiosteal layer at the very young age. So he gives an obturator and the child they uh, take care about the feeding, but the speech is established because the soft palate has been done. This is one concept. The third concept in the developed era is Dr. Robert Mann. If you read about Dr. Robert Mann's technique, he uses buccal flaps to lengthen the soft palate. Till date, he is the only person who is using buccal flaps for primary palate. We have in India, we have a longest case series by Dr. Jaideep. He is using buccal flaps for secondary cases. But for primary, if we use buccal flap, according to Dr. Robert Mann, is a very elderly man. His case series has shown astonishing. Only less than 3% of cases requiring secondary jaw surgeries. So that is one thing we should look at it. But to do that, still the world is not open for that because again you have to borrow into buccal flaps and then the child you have to have a very good setup, a neonatal setup to do that. Because if there is a trickling, if there is any construction, airway problem, you have to have a very good ICU backup. Then of course you can do that. But that is a fantastic study, very astonishing result. I think the whole world should take inference from that.
Yeah, that was good. But then, like, what is your take on like in any surgical procedure? We know that the flap has to be closed without tension. So I think same holds good for even in cleft surgeries as well. So what is your take on, I mean, how far would you prefer to dissect to get a good closure? I mean, would you prefer a good subperiosteal dissection till the zygomatic arch and then get a closure? How exactly do you?
We don't do delay, we don't go towards delays philosophy. We do
Mm.
supraperiosteal dissection, but
Mm.
because of opening of nose, we get
Mm.
good nasal symmetry, alveolar
Mm.
symmetry, and all those things can be established if we do open killer rhinoplasty. You need not
Okay.
go so aggressive towards periosteal elevation. So we
Okay.
follow that, and we are able to get good amount of results.
Okay. There is one more question which has come up in the chat. That is when one can perform tertiary alveolar bone grafting. This is, I think, Dr. Pragati Jain has asked this question. When one
So
can perform a tertiary alveolar bone grafting?
the tertiary alveolar bone grafting usually towards reconstruction at the last. We have a good good arch position. We have we have done rhinoplasty everything. At the last, we have to do rehabilitation of replacement of teeth. So during that time, yes, we can do the tertiary bone grafting. We have artificial bone grafts also. We can with a marrow, and one literature states that we can take both the marrow as well as the cancerous bone, make it as a plug, and we can plug it and put an implant immediately. There is one study, but the success is not a long study, so we don't know the success rate. But even if you are doing that tertiary bone grafting, you can immediately do an implant. That is the recent advancement. But we need to watch and wait and watch, because in case if there is a load, and then if there is a graft failure, all those problems will be there. But the ideal time to do that is during the rehabilitative phase.
I think as for now, we don't have any more questions. We can expect more questions as we go ahead with our session. I think we can go for the next session.
Thank you.
Yeah. Would you like to take a break, Manu?
No, secondary deformities, I will finish the surgical aspect. Then the
Okay.
multidisciplinary team will take care. Then I will.
I think meanwhile we have got yeah, one more question which has again come up. I think it is in YouTube. We'll address that. How to overcome the complication which occurs due to iliac graft. That is, especially they're asking about gait deformities.
Okay. So to go to iliac bone graft, what I would usually what we suggest is people who are already into that, I mean, already exposed to getting harvesting bone grafts, uh, kindly assist them a lot of time, and then get into harvesting bone grafts. Usually, what happens is in an institutional setup it is fine, but when you are doing a private setup, it is really difficult because of the medical legal aspects already. Um, the few things which we all need to take care about especially in the iliac graft is the medial aspect. So the medial aspect is the place where if the instrument is slipped, we can have a perforation. So this is the most detrimental complication which can happen, and the the precautionary measures are we have something called abdominal spatula. Usually the approach should be on from the lateral. You should never. There are few techniques which the medial approach is there for the anterior iliac crust, either medial or lateral. But the preferred for alveolar bone grafting should be lateral. But if you are doing a reconstruction, then the approach can be medial. No problem with that. But if you have an abdominal spatula guarded, and then you have a osteotome with a minimal force, all the complications can be saved. That will be the key, to have a guard on the medial side, that's the abdominal guard.
But I think taking a graft for alveolar bone, that is secondary alveolar bone grafting, is different from the graft we take for whole whole mandible reconstruction because we require a corticocancellous graft and the quantity is very less. But the question again is very specific, like what would you do for a gait deformity? Like what would you exactly do for gait deformity? That is what they have asked.
Gait deformity.
Yes, yes.
I'm not getting exactly what the question is.
Okay. Okay. Maybe they are talking about the gait. Because of the bone grafting, there will be some gait deformity post-operatively. So I
Okay.
think that rest and things should take care of it. I guess, like if it
Uh,
occurs also. Yeah. But yeah, of course, healing takes longer time in iliac grafting. And I
yeah.
think now they come up with something wherein they can irrigate daily with some put a perforated tube inside and then allow that region to be irrigated on regular basis or something like that.
The one modification what usually can be done is the refine, because
Yeah.
alveolar bone graft usually we require only narrow space. So the
Okay.
refine can be used if we are not opening up either by trapdoor or any other core modifications, either splitting or pediculing. Uh, a, refine can give us a straight marrow without opening up the bone flap, and then
Yeah.
that is sufficient for a alveolar bone.
Alveolar bone. That's true because the quantity and quality of bone that is required for SABG is different from other kind of reconstructions. Okay, I think we can go ahead, Dr. Man. We can go ahead, I think, with next
So
session.
secondary deformities of cleft lip, nose, and maxilla. This, because it is a very basic lecture, we'll be rushing through this and we'll be more concentrating about multidisciplinary approach. So the secondary deformity of cleft lip and nose is mostly aesthetic but functional as well. So if there is a disfiguring scar, skin shortage or excess, orbicularis oris muscle malposition or diastasis, lip landmark abnormalities, vermilion deficiency, the visual deformity, mucosal contracture or buccal sulcus obliteration. These are the few indications where we need to either redo the whole lip or at least open up a part lip and do the corrections accordingly. So the indications mainly depend on the anatomic abnormalities identified by the surgeon. That may not be the true indication always, but the patient's expectation towards anatomical distortion you have to take into consideration. But if there is a smaller child, then anatomical factors, desired improvement by the family or the parents. So these will be, apart from functions, this will be the indications for uh, doing secondary. So in this case, if you see, uh, there is there is a primary surgery done already. You have, again, we always come from top to down. There is a deviation of the nose. There is a drooping of the ala. The cleft ala is drooped. There is a scar. There is a peaking of the cupid's bow. There is groove. The muscles are lumped on the non-cleft side, and there is thinness of muscle in the cleft side. This is the classic cleft lip, secondary cleft lip and nasal deformity. So, what things we see that has to be improved. So, what should be improved is get the septum into midline, get the alar positions into place, get the ala behind the columella, drop down the lip by opening up the lip completely. The cupid's bow has to be taken down. The tubercle has to be achieved, and then you have to have a good volume of lip, and the visual deformity has to be obliterated. So these are the aspects what you need to look at it in a secondary cleft nasal deformity. It is totally different from primary nasal deformity and the primary lip deformity, because uh, there the alar positions also will get affected. But here the planning becomes very important. The planning, you and the patient has to be conjointly planned, and then they have to take a decision of what has to be done during surgery. Because some patients may, if you look at it, some she might feel that only the lip is primary obstruction or the concern. But if you see the nose as well, that also will be a concern. If you see a male patient, then again the hair in the mustache also plays a major role. If you plan properly your incisions, we had planned incision on the less hair bearing area, and without doing any hair transplant or anything, we can get at least this much lip thickness and the hair thickness. If we design our incision properly, we can have this kind of an hairline continuation. And then, of course, the lip fullness, muzzle refilling, alar position, midline, and then alar position, and then this alar rim position. So these many things has to be added. What in this you can't see is the alveolar fistula. Alveolar fistula also will be closed during this time. So in one go, you will be doing fistula, then your lip, and then your nose all together. So that's how few of the centers individually it will be tackled, but we would like to tackle it as whole as possible, because it burdens the burden of care will be reduced for the patient, for the organization, for the supporter, everybody. Rather than doing 3 surgeries, if you can do it at one go, all the things, the general anesthesia giving time will be less, and then the longevity of the treatment can be concise to one go. Otherwise, it would have been 1.5 years to get this result doing 3 surgeries. This photo I wanted to show you that if you see closely observe, there is not much of a visual deformity, but if you see the continuity of the lip which is done, it is the continuation of vermilion or the cupid's bow is going almost towards the nasal base, and there is a dip in the nasal seal. So imagine you have to get this length, that means nearly about 1 to 1.2 centimeters of length by rotation without altering this architecture. Either you can improve, but you should not alter this. So this is the rotation. It's a very big challenge to get the skin here. So if you see this, again, the hair bearing incision will keep a track. But if you see this, this is the most trickiest part to get the length of in the secondary, because in the primary you have tissues. In the secondary, it is very, very difficult to see where the tissues are, how to rotate it without altering anatomical subunits. And then the nose, according to the management, the abnormality of cleft lip and palate has been studied, but the nasal deformity emphasizes a more observation than lip as the patient grows. So if you see the anatomy, I explained you already. This is the drooping. The drooping of columella, the columella happens anteriorly, forwards, and medial. So that's how it happens in 3 directions. So when we are reconstructing, we need to pull the cleft affected alar dome in all 3 directions. That is superiorly, medial, and then towards midline. So all 3 directions. The deviation of septum will be there, that has to be considered, and then alar webbing or gap will be more, that will be widened gap will be more, that has to be considered, deviated nasal septum, and then all the things will be attached to anternasal spine. So that has to be released and taken into midline. So this is one of the difficult cases we had. You can see there is a big group of alveolar nasal margins. Lip is narrow, there is thin lip, the scar is big. We don't have enough showcase of columella, and then the bony part is also wavy, it's not smooth. So with this, what happens is we used for this nasal augmentation by urosilicon, and then we did a nasal osteotomy. We got a columellar graft. You can see the lip is improved, the scar is improved, the columella has been highlighted. You have a very good nasal dorsum. The nose, he is pretty happy in the lateral, especially. and then the complete rehabilitation has been taken care. Similarly, this is the final comparative photo. Similarly, in this case also, we have done lip revision, rhinoplasty, having a dorsal augmentation, nasal osteotomy, elevating the nose, nasal osteotomy here, dipping the nose on this side, getting the nose into midline, and getting this alar position, alar rim position in place. So this gives the holistic approach. If we do only lip, it is difficult to do a rhinoplasty later because the above area from here onwards is also in continuation with the nose. So in cleft, ideally, if you do combined lip and nose all together, you can achieve a very good harmonious relation. If you do rhinoplasty as a single entity, then you should have a very good lip already in place with the alar positions in place. Then you can do only rhinoplasty. But if not, then you should always do combined procedure to get a very good results. So palatal fistulas are usually because of the breakdown of the primary surgical area or failure of healing. The most commonest points are the anterior alveolar fistula at the midline and at the posterior. It usually runs from 0 to 35%, and then the repalatal fistula rate is usually 80%. So if there is a fistula already, then you are reoperating and then 80% failure chance on that. So, but in our institution, it is less than 1% because of detailed attention, and we are doing 3-layer closure. This is an anterior palatal fistula. In this, what we did is anterior rotation. So I'll just tell you about what all ways you can do address the palatal fistula. This is a rotation flap from the adjacent greater segment, and then the gap, what you can see here, it will be filled with the mucosa because it is on the bone. So the periosteum is been detached, so there will be a regrowth of mucosa. Okay. So second is, if it is at the bilateral in the midline or towards the anterior, you can take buccal flap. Okay. So labial flap, you can say buccal flap will be down. The labial anterior mucosal flap, or you can call it as finger flap. You can take harvest, run it from there, any alveolar gap which is there, and then you can close the primary defect. Okay. And then here you can either put your dressings or cotton or anything, and then it will heal up. Okay, you need not do primary closure, because if you do primary closure, you will be shortening the vestibule or the shortening the lip. So it will regranulate. So this is one of the ways how you deal with palatal fistula. If you see the ladder of palatal fistula, first should be the rotation, second should be the adjacent flap. That could be either finger flap, palm flap, buccal flap, or anything. Then next step, you should go for tongue flap. Even if that fails, you have to go for artery-based flap. That fails, you have to go for temporalis flap. If that fails, then you have to go for free flap. That's how the step ladder management of palatal fistulas. And then this is one complicated case what I wanted to share you. This case we didn't do anything. We did a decent redo palate. That's all. We could not concentrate on the muzzle properly because there was no muzzle at all. The whole length was done by just redo palate. We didn't use any other flaps. So why I wanted to communicate in this slide is, if you do thoroughly, delicately handle tissues, give respect to tissues will heal properly. So don't think that tissues are not there or anything like that. If you deal with the tissues properly, I think the nature will take care about the best results. So the challenges to achieve low palatal fistula rate is a very nice retrospective article. The article link also I will share. You can kindly go through. What I told just now, the step ladder will be explained in this. Next is the premaxillary osteotomy. There are many ways: external elastic traction, closure of cleft, that is called lip adhesion, and then intraoral elastic traction and surgical setback. In this, I am showing surgical setback But in the multidisciplinary approach, I will show you in the recent times how we are managing the premaxilla. We have a really good NAM results that will be shown to you at a later stage. This case, before we started NAM, this patient came to our center. Palate was done, tried, but there was a failure because of the wide palate. Premaxilla was very ahead. So we could not do the lip closure very initially. So what we did was first premaxillary osteotomy and then positioning the premaxillary in a position and keep a splint. After that, we did a primary lip surgery and then the redo palate was done. So that's how the treatment plan was based for this child. And then that's how we could achieve the closure. In this case, he had undergone somewhere primary lip repair. This was the premaxillary osteotomy. Premaxillary osteotomy, there are many things to consider, but I'm just rushing through. The premaxillary osteotomy was done. Premaxillary osteotomy stabilization is a very, very big task. There are many methods like splint, wiring, we have screws, or even we have plates, but which aspect we open and then the compromisation of blood supply is the key to stabilize the premaxillary segment. In this case, we could stabilize by splint and wires. So then next is anterior maxillary distraction. Okay, this usually for a mild to moderate maxillary hyperplasia, we can do anterior maxillary distraction. So anterior maxillary distraction will be done according to the patient selection, where there is less than 6 millimeters of, you can still do more and you can do staged and all those things are there, but generally speaking, for a mild to moderate maxillary hyperplasia, the posterior, I'm not going too in detail because all these small aspects are all actually more than 1.5 hours of lectures. So the anterior maxillary distraction, we usually use Hyrax, but in a different direction. It's a perpendicular direction. Appliance formation is completely ortho lecture. So in this case, what we have done is we did osteotomy, made like a splint. It's a modified appliance where the anterior complete segment is compensated. So the force is not directly on one tooth or two teeth. So this mobilization, we achieved this long results. And then cleft orthognathic surgery, where now the most centers are going towards maxillary distraction than lipodostomy. There is still a debate, but majority of the centers which have already have a lot of big volume of lipodostomies, they claim that the speech was never altered. But the recent debate says that at least not to decompensate for the cleft speech, we can do the cleft maxillary hyperplasia by anterior maxillary distraction. So again, just to complete the secondary deformities, cleft orthognathic surgery, yes, we can do lipodostomy and then get the maxilla in front. And then for bilateral, even after AMD, if still the maxilla is not coming forward or this is the maximum which can come forward, then you can do BSS. Then you can achieve the facial harmony. Okay. So there is a big debate versus maxillary distraction versus orthognathic surgery. You can see the literature. Sometimes there will be consensus, sometimes there will be different groups claim that success rates are good in each aspect. So this will be, this is the primary surgical, primary cleft treatment by surgical aspect. Now we will go to the second phase, that is the multidisciplinary approach. Anis will start from multidisciplinary approach. Anis, you can start screen share. I will stop the screen share. One minute.
Good afternoon, everyone. Am I audible?
Yeah, you are audible.
Okay. So far, we were listening to the surgical aspects and the anatomy about the cleft lip and palate. So I am just going to run you all through the comprehensive cleft care, which we started in our Mysore Center in the year 2018. So what is comprehensive cleft care? So it is, in a simple term, we can say it is a total rehabilitation for all the cleft patients. It's a serious condition, but the challenges can be overcome. That's the good news. So children born with cleft lip and palate deserve to be supported every step in the comprehensive cleft care. So we make it possible at our center. So what do we do in comprehensive cleft care? These are the list of our team members who work in our center here. So this is called the circle of cleft care. So we start with the newborn nutrition. So whenever we have a new patient coming into our center, so we basically look at, if the baby is healthy, we check the head circumference, the height, the weight, and things like that, and look at the HB percentage as well. And if at all we find it to be low, we help them with the nutritions which are required as the case may be. And next we go into counseling. So this is more important to the parents as such, because whenever there is a newborn at home, the expectations would be, the baby would look beautiful and everybody is happy at home. But when there is a case of cleft lip or a palate, parents are totally disappointed as to, how they go about it. And most of the parents do not know about this issue, or they are not aware of this deformity as such. So when they come to us, they're in despair, and we counsel them and let them know that, this is treatable, and we are here to assist them in every aspect of the treatment here. And most of the patients are from the rural areas, so we help them with the transportation assistance and the parent support, whatever they require from the time and again. And then we have orthodontics. I mean, yes, the cleft lip and palate patients have a lot of issues with the ortho. And so with the dental care as well, they have a lot of caries and things like that. So we do the filling. And then we have the ENT problems, the hearing problems. And then ahead we have the speech associated problems as well, along with the surgery for these kind of patients. So if you can see, this is a circle. I mean, this is something that is required by each and every patient, and we are here to give them a complete rehabilitation for our cleft patients. So this is a picture wherein we counsel the parents and tell them that we are here to help them. So Dr. Harish will continue here, giving you a more detail about the nutrition, feeding, and NAM aspect. And furthermore, I'll continue from there on.
Once I forgot to introduce, and in this time I want to emphasize the role of project coordinator, because the surgical team, there are surgical team, there is dental team, there is ENT team, there is field worker. So everybody in the team has to be put in it. So that is the role of project coordinator. I think we have a today we have Anis amongst us. She's our project coordinator at our center. She'll be mainly having coordination between the patients, surgical team. Counseling is a major part of hers, and then this coordination between the surgical team, non-surgical team, management, patient, it's a huge task. It cannot be done by on the other side. So this dedicated person is a real important place in any center. So if we have somebody who is really good in this, and then the center can grow very nicely. Now Dr. Harish, he is our assistant surgeon in our Cleft center. He'll be talking about nutrition, feeding habits, and then pre-surgical evaluation and NAN. Harish?
Yes, sir. Good afternoon, everyone. I'm Dr. Harish. I'm working as an assistant surgeon in the center. So I'll be talking about the nutrition, feeding in cleft child, and the nasal alveolar molding. The most immediate concern for a baby with a cleft palate is the good nutrition. So what happens? This child have a difficulty in sucking. This is due to the defect in the lip and as well as in the palate. So they have a fine difficulty in creating negative pressure and lip seal. So what we recommend them is a small, frequent meal. The parents may find it is frustrating as slow process, but this technique will definitely helps in increase by receiving better calories as well as gaining a good weight. So we have the different methods and position the feeding. So we facilitate feeding in these children. So one technique is the modified football method or the straddle position feeding. So this method is indicated especially in cleft with the unilateral cleft child. And another is the dancer hand position. So this method helps indicated in bilateral cases. The correct position for the feeding would be in the upright position. The baby should be held in upright position in around 45-degree angle. So this is a better, the child can have a better feeding in this position. The incorrect position would be in the supine position. The child should never be fed in supine position. So the chances of aspiration is very high in supine position. There are other specialized feeding bottles designed for the cleft child, like the Heberman's feeding bottle or feeding bottle with a spoon, the Mead Johnson's cleft nursing bottle, or the baby feeder, or the cross-cut nipple. These all are specialized bottles or feeder for the cleft child. But coming to nutritional assessment, in our center we assess the nutrition in every visit of the child. So we assess the weight of the child, the head circumference, and the height or the length of the child. We call the patient once in every 15 days for 3 months until primary lip surgery, and every visit we will be assessing the weight, all these 3 parameters. And if we find that the child is not gaining weight, I will refer the patient to pediatrician and you give nutrition supplements. Coming to nasoalveolar molding. So nasoalveolar molding is a non-surgical method of reshaping the gum, lip, nose before cleft surgery. So NAM appliance is a small removable appliance which is similar to an orthodontic retainer. So what NAM does is it applies pressure to decrease the severity of the cleft and improve the shape of the nose. It also helps in redirection of the growth. So it helps in closure of the alveolar segments. So NAM was developed in 1990 at New York University Medical Center by an orthodontist, Dr. Barry Grayson, and a plastic surgeon, Dr. Kurt Cutting. So we started NAM therapy soon after the birth. This is within early first week after the birth. The success of the reason for success of NAM therapy is due to the presence of high level of hyaluronic acid and parenteral estrogen in the circulation. So coming to the objectives of pre-surgical nasoalveolar molding include to provide the better symmetry of the lip and the nasal cartilage. It helps in achieving the projection of flattened nasal tip. It provides non-surgical elongation of the columella, especially in a bilateral lip cases, It also improves alignment of the alveolar ridge, and it reduces the size of the cleft, so it helps the surgeon to get a better shape of the nose and a minimal scar in the lip. So these are the few cases we done NAM at our center. This child visit our center in early first week of after birth. We took an impression, we delivered the NAM plate along with the nasal hook. At the end of 3 months, just before the surgery, we could achieve an excellent result. We could achieve elongation, columellar lengthening, a proper projection, nasal tip projection, and good shape of lateral alar cartilage, and even the reduction in the alveolar, cleft segments. This is a child after birth, child with a NAM plate and nasal hook. So this is another case of a bilateral lip. The same we can took a patient child received the NAM for 3 months. This is after just before the surgery. We could achieve an excellent lengthening of the columella, well shape of lateral alar cartilage, and reduce alveolar cleft segments. This is an article which explains about NAM. It's a good article. So now I'll hand over to Ani, so she'll continue with the comprehensive care. Thank you.
Thank you, Dr. Harish. I'll continue now with the comprehensive cleft care treatment. So apart from NAM and nutrition, we continue with the pediatrics. So it is also associated with the nutrition. So you can see the pictures are from our center where we are giving the nutritions to the patients free of cost. Of course, the surgical team here, Dr. Manu Prasad and team. This is Dr. Veena giving the orthodontic and the dental treatment to the cleft patient. And Dr. Praveen Kumar, the ENT specialist and the surgeon here. We also do ENT surgeries as well, apart from the ENT treatments for the ear infections. Next comes the patient search and awareness camp. So this is the door-to-door visiting of patients. I mean, in the villages, we do door-to-door visiting and personally visit the patients, talk to them, and educate them about the cleft and the treatments and what are the possibilities that they can get free of cost. One of the talk at the Anganwadis, awareness camps at school, and spending time with some of the school kids, educating them about this kind of a deformity, which is cleft lip and palate. And these are some of the pictures of the camps that we regularly organize with the help of some of the Lions Club or the Rotary or the RBSK. So now I hand over the talk to Dr. Veena. She will take care and talk about the orthodontics. Dr. Veena, you can start now.
Good afternoon, everybody.
Yes, Dr. Veena, we can hear you. Kindly continue.
Yeah. My slides need to be changed. Anis?
Yes, yes.
Yeah, once again, good afternoon, everybody. And I'll be talking about the importance of orthodontics in cleft patients. And as we know that patients with cleft lip and palate, it's a lifelong journey of multidisciplinary care, starting from before birth and extending until adulthood. And as NAM has been explained by Dr. Harish. Next. 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 Okay. Coming to the aim of the orthodontic treatment in cleft patients, the first foremost goal is optimal aesthetics, which the patients are more concerned. As an orthodontist, we are more concerned about the function and the stability of the occlusion, but the patient's first priority will be the aesthetics, because when they come to the teens, the smile, uh, the smile with teeth. As we know, the smile is important to build the self-esteem in the patients, especially when they are in the teenage, for both the males and the females. So the role of orthodontist in timing and sequencing of treatment is important in terms of overall team management. The orthodontist needs to make critical decision for orthodontic intervention at the appropriate time and prioritize treatment goals for each intervention. Next. Next. The orthodontic intervention can be divided into stages. The stage 1 includes from birth to 2 years, where the NAM is done and the lip repair and all the palatal repairs are done. Then after the second stage, next, the primary dentition stage. This is the stage where orthodontist intervenes. The first and foremost is the crossbite. In cleft patients, there is no uniform arch shape. There is a breach in the continuity of the arch. And also there is disruption in the transverse and the anterior-posterior expansion of the arch. So usually the transverse expansion which establishes first, and later the arch grows anterior-posteriorly. And in this patients, the transverse expansion of the arch is collapsed, leading to crossbite. And that has to be addressed first. And this can be addressed in the mixed dentition or early in the primary dentition also. We can use many appliances for crossbite that could be fixed or removable. And also after this, monitoring the appliance and oral hygiene instructions has to be given. Next. And coming to the mixed dentition stage, arch expansion to correct posterior crossbites, there are many appliances like jack screw, quad helix, night-eye expanders, rapid maxillary expanders, and orthopedic appliances like protraction face mask, also called reverse pull headgear, and bone grafts and fixed orthodontic treatment can be initiated at this stage. Before starting the fixed orthodontic treatment, correcting the crossbite and also the anterior posterior dimension of the arch is very important. These both has to be achieved first. Then it's better to start the orthodontic treatment. And important to achieve this transverse is mainly for grafts. Where there is a cleft, there is defect in the alveolar bone, and the canines or the laterals usually get impacted. Because of deficiency of the bone, they cannot migrate down. So after expansion of the arch, creating enough space for the eruption of canines and laterals, the grafts can be placed, and later that can be, the tooth can be pulled out with the help of orthodontic treatment. Next. These are a few images of expanders. We can see we can achieve very good expansion with the arch expanders. The first images of night palatal expanders, and also the second one is also expander with screw. We can custom made, the appliances can be custom made also depending upon the need of the patient. Next. Yeah, these are rapid maxillary expander. There is a controversy on rapid maxillary expanders because since there is no bone, the expansion can be achieved sometimes just with simple palatal expanders. Need not go for rapid maxillary expanders. The indication of this RME is when there is severe collapse in the arch. And then we can use, and also the protocol for opening the screw, it differs from normal patients with crossbite to the cleft patients. Next. This is a case where there is collapse transversely and also anteroposteriorly. And the image shows the expansion achieved, and also the anteroposteriorly, the bite has been jumped. Next. This is a removable appliance. It's called as 3D expansion screw, in which there are two screws placed. One is for transverse expansion, and the front is that is for anteroposterior expansion. Both can be achieved in the same appliance. Yeah, and coming to the orthopedic appliance, it's a face mask. As we know, the maxilla is deficient anteroposteriorly, and the catch-up of the maxilla usually doesn't happen in these patients. So we need to do it by putting the face mask. And also in these patients, there is something called a safety valve mechanism, in which the upper maxillary canine holds the mandible in a right position to get the intercanine width properly. But in these patients, since there is no maxillary growth, so there is no canine, the mandible is set free to grow to the maximum. And that is also a reason, for excess maxillary growth in these patients. So if we intervene with the right time and use the face mask therapy, we can restrict the growth of the mandible, as well as we can promote the growth of the maxilla. And all these face mask therapy usually associated with the expansion. The first step is expansion. The arch has to be expanded. Then later we can do either orthodontic or the orthopedic therapy. Next. Yeah, this is a case, mixed dentition, where the maxillary growth has been achieved. Okay. In orthopedic appliances, the importance is the pubertal growth spurts. And as we know, pubertal growth spurts are very early in females and little late in boys. So initiation of the orthopedic or expansion or whatever the therapy has to be a little earlier in the girls than in the boys. If we miss the pubertal growth spurt, then it's very difficult to correct, and it has to be, it's end in a surgical procedure. So after the alveolar bone grafts, this is a sectional cone beam computed tomography of pre and post formation of alveolar cleft site, the 6 months after the post iliac bone graft. So once for an orthodontist to bring the tooth down, alveolar support is very important. If the bone graft is successful, the alveolar bone grafts, then it's very easy to pull the tooth. And once the tooth is out, the tooth around the bone around the roots is well maintained because of the tooth. Next. So I think this has been covered, the principal benefits of alveolar bone grafting to provide sufficient. And coming to the permanent dentition stage, here where the fixed orthodontic treatment is completely done. And after orthodontic treatment, surgical planning can be done. And whether it is a distraction osteogenesis or maxillary or mandibular surgery. And at the end, which is completed by prosthodontic rehabilitation and followed by retention of the established occlusion. So patients fixed, there are some cases we can correct the case only with fixed orthodontic treatment where surgical intervention might not be needed. Such cases are patients with no much skeletal deformity, with mild skeletal discrepancy, and with moderate to severe skeletal discrepancy may achieve the best aesthetics and functional results through a combination of orthodontic treatment that is carefully coordinated with orthognathic surgery. So these are the few cases. This is corrected only with orthodontic therapy. No other surgical intervention has been done. In the first, we can see the cleft defects and the arch, the gap where one tooth has been extracted and the whole segment is moved forward anteriorly so that the cleft gap is covered. There is no prosthesis also in this case. Next. This is another cleft case where this is called as running pontic with the braces. Then after it can be replaced by the prosthesis. Next. So sometimes maxillomandibular skeletal discrepancy is severe, and for psychosocial reasons, early surgery during the mixed or permanent dentition might be indicated. At that time, we need to start the orthodontic treatment a little early. This is a surgical case corrected by surgery, maxillary deficiency. Next. This is a bilateral cleft patients with two jaw surgeries after the orthodontic treatment. Next. And distraction osteogenesis, when the skeletal discrepancy is beyond the scope of surgery. So distraction osteogenesis can be used, can be done, of course, after the orthodontic treatment. Next. Next. These are the distractors. There are varieties of distractors, intraoral and extraoral. Both doesn't interfere with orthodontic treatment. Next. This is a case, bijaw surgery is done. Next. So this is a series of patients treated with Lefort 1 and with the orthodontic treatment. Next. Sorry for the image. In this expansion is done with the arch wide, and later is this a prosthodontic rehabilitation. The whole mouth, the full mouth rehabilitation has been done. We can appreciate the expansion in this, and which expansion is done at the right age. I mean to say, before the puberty for the girls and both for the boys, we can achieve the maximum expansion of the arch, and we can accommodate the tooth. The only thing is the relapse. Since the palatal scar tissue is very stubborn, as soon as you remove the appliance, there are chances of it, to collapse again and creating the crossbite. So permanent retainers or fixed retainers might be indicated in cleft patients. Next. This is a simple quad helix which has been fixed, and we can appreciate the amount of expansion which has been achieved. Okay, these are the cases where expansion has been done, and both anterior-posteriorly, transversely, we could have jumped the bite, and we could do good finishing in ortho. This is the follow-up of the case. Of the same case, started at 6 years and at 20 years. This is also a similar case. Next. All these cases are where the arch expansion has been maintained, because once we start the braces at the age of 10 years or 12 years, the braces goes on after the surgery also sometimes, just to maintain the arch, expanded arch form, until normally the orthodontic treatment might go for 2 years maximum. But in cleft patients, sometimes we need to maintain the appliance at least for 3 years or 4 years to maintain the arch stability and until they reach the puberty, so that the relapse rate will be less. So the successful management of patients with cleft lip and palate requires careful coordination of all members of the cleft team, and the clinical techniques constantly will be improved to enable the clinician to provide the best possible care while striving to reach the goal of excellent facial aesthetics in patients born with clefts.
Thank you, Dr. Veena. From here on, we go ahead with Ms. Pratiksha, who's our speech therapist at our center. Ms. Pratiksha.
Good afternoon, everyone. Myself, Pratiksha, speech language pathologist and audiologist. Today, I'll be discussing about speech and auditory problems related with cleft population. How do we produce speech? Speech is usually produced by the air coming from the lungs to the vocal folds and finally reaches the mouth, where the air is sound into shapes. The shape will be given with the help of tongue, lips, and teeth in order to say sounds or words or even phonemes. Most of the sounds we produce are made with the palate raised cavity, except for the sounds m and lowered palate. This is a chart which is showing this typical speech developmental in normal growing children. So we usually consider the age from 3 to 6 years as a critical age where the speech vigorously develops within this age. So if we start any therapy, it should be started within the 3 to 6 years of age for the more benefit and better results. So in our field, we distinguish sounds based on place of articulation and manner of articulation. Place of articulation is nothing but it's based on the anatomical structures. Manner of articulation, it goes with the physiology of structures. So this is how it is classified, place of articulation and manner of articulation. So depending on lips, dental, alveolus, depending on its involvement, the sounds are divided. There's also another major classification, that is anterior sounds, posterior sounds, and medial sounds. The anterior sounds are nothing but the sounds which are produced at the anterior region of the mouth, that is the front oral structures, and posterior is just opposite to that, the back structures of the mouth. These are two aspects which is very important for speech development, that is articulation, resonance, nasal air emissions, velopharyngeal adequacy, language, voice, and fluency. In cleft population, all these aspects will be disturbed. The whole speech gets disfluent. When it comes to articulation, there are three triad symptoms we usually see with cleft, that is hypernasality, misarticulation, or even compensatory misarticulation. These three symptoms are considered as triad symptoms in cleft population. Resonance. Resonance is nothing but it deals with hypernasality and hyponasality. 50 to 60% of the cleft population will be affected with nasality, and they will have hypernasalized. Nasal air emissions. This is a severe form of hypernasality. In hypernasality, we can just hear the nasality effect. But whereas in nasal air emissions, we can also visually see the emissions. What we usually do is we keep a piece of paper under the nostrils of a patient and we ask them to speak. Whenever there is nasal air emissions, the paper gets vibrated. And this is a sign and symptom of nasal air emissions. So accordingly, depending on the severity, we give treatment for that. Language. Because when speech is affected, the whole language gets affected. So in 50% of the cleft population, there will be an expression delay. And also there will be inadequate language skills. The whole language development gets delayed, and semantic skills are also affected. That is, their vocabulary will be affected. Instead of speaking 10 words in a sentence, the child tries to speak 5 words in a sentence. So the whole MLU is reduced. MLU is mean length utterance. The number of words used in sentence will be reduced. Voice. When it comes to voice, again, the three parameters are very important in voice: pitch, volume, quality. We assess all these aspects in starting evaluation. So the voice of cleft speech will be like very monotonous or diplophonic. And when it comes to quality, it might be hoarse, breathy, or the combination of all these quality. Auditory problems. The two main problems we face with cleft is, one is hearing loss and another one is severe infection, that is otitis media. Because of the abnormal opening between the oral cavity and the nasal cavity, the fluid directly it enters into the middle ear, that is medial part. So the fluid which is accumulated will lead to a severe infection, that is otitis media. If that infection it's not treated on the proper time, it leads to permanent hearing loss. So here the ENT surgeon is involved for the surgery because of the infection. During the surgery, this pus formation or the fluid accumulation will be removed through the grommet incision. Assessment part, we assess each and every aspect, that is articulation, voice, language, speech, everything. We have a standard tools for assessing language, that is reels and P-body picture test. To assess nasal air emissions or hypernasality, we use instruments like mirror test, air paddle test, stethoscope test, and listening tube. If we don't get a proper results with the smaller test, we go with the higher test, that is nasal endoscopy or video fluoroscopy. By getting a proper picture of the results, based on that, we plan for a treatment or speech therapy. When it comes to management, it's a multidisciplinary managed. speech therapy. So here in our center, we are just not focusing on speech therapy. We also focus on language stimulation therapy, direct individual training, group training, and counseling. We set goals whenever it comes to speech therapy. The main goals we set for cleft population are like this: to establish age-appropriate speech patterns, elimination of misarticulation, reduce hypernasality, maximize the range of PP motion, and generalizing the oral production like near to normals. Prior to speech therapy, we prepare the speech structures and muscles for a speech therapy, proper speech therapy. So we give oromotor exercises or oral exercises for them, like pointing tongue, fishy mouth, whistling, sucking, blowing. These are few exercises which are given to them prior to speech therapy. This is also usually given for neonates and infants because they can't be directly indulged into speech therapy. So before starting a speech therapy, till the age of 12 months, these exercises can be given to the parents and we can ask them to do it for their children and then come back to speech therapy. These are few proper speech techniques: auditory feedback, biofeedback, visual feedback, prompting, cueing, and imitations. In this picture, I'm doing a tongue stimulation therapy for one of our patient who's named Sadhya Gowda. His speech was a little bit complicated because along with the cleft, he also had stuttering. So his diagnosis was like cleft lip palate along with the stuttering. So after a few sessions, I've seen a better recovery in him. And this oromotor stimulation therapy helped him a lot. This is an individual speech therapy where the child is sitting with its mother. And usually for the smallest children, we indulge their parents to in therapy so that it will be more easier for us to manage the child. And this is a group therapy where 3 or 4 members together, I take up therapy for 3 or 4 people. And we also did an intensive speech therapy last month, and we saw really a drastic recovery changes with the samples which we had. Telerehabilitation therapy. During this pandemic, it was difficult for us to reach all our patients together. So teletherapy helped us a lot to reach most of our patients, and they all continued with a good speech therapy, and successfully we managed to do it. And this is audiometry and otoscopy examinations. Whenever they come for a speech evaluation, every cleft patient will also undergo a audiometric test. These are few pictures that were taken in our camps that we usually do at Sargur VMH camps. And this is another clinic where if the higher tests can't be done in our center, we'll take them to a special test and these tests will be done for them.
So now we have almost come to the end of the whole topic, except this is the major one, surgical has to be done. So, craniofacial clefts. Now we really got to understood about primary cleft lip palate nasal deformity. We got to know about the whole arena of multidisciplinary approach. Now a bit higher, if you go, these are the little complicated craniofacial clefts. So as such, cleft lip and palate requires a thorough planning skill and in terms of really planning. But if we go to the next one. So these are the various cleft presentations which can happen. As we all know that face has many vital organs adjacent to the oromucosal structures. There is lip, there is eye, nose, and then the posterior aspect. So if all the craniofacial cleft, which most disfiguring cleft, but if it affects the normal vital structures, then the addressing will become very difficult. So this is one of the case, the etiology, statistics, and all. One thing is because of the rarity and because of the less number of cases, the standard, like we spoke about lip, palate, concepts, techniques, but in this we don't have to treat these kind of cases. But the universal classification, at least it is approved, it is usually Tessier's classification, which usually depicts according to the numbers. This is the Tessier's classification. From midline, it crosses this 1, 2, 3, 4, 5, 6, then 7 is the lateral cleft, then 8 is the near the eye, the lateral cleft, 9, 10, 11, 12, 13, and 14. So the midline cleft. Then down it is 30. Similarly, it can affect it can present in soft tissue and hard tissue. So the facial clefts in our statistics, roughly about 3,000 cases. The facial clefts are about 16, and then Tessius 7 is the most. We had a bit of variety of cases. This is one of the cases which came to us with primarily treated with lip, but the whole facial cleft were still was to be addressed. Palate was to be addressed. Eye got keratinized, unfortunately, because of exposure. And then this kind of presentations lead us to think a lot, get to know what could be the consensus, what could be the incision, which doesn't affect the normal anatomical structure, and it doesn't disproportionate the structures also. This was the CT, and this was the planning which we could do. And then we got to know, we got this alar cartilage inserted into the midline, lip was done, palate was done, this nasal cavity was closed, this excess tissue was removed, and this was the lateral incision to mobilize it. And he was presentable, but still he had a lot of other treatments to be continued. Unfortunately, he was happy, and he told that is enough for him to lead a life. Similarly, we had this girl who had Tessius oblique facial cleft. One thing I usually suggest is to have this kind of planning material in your operation theater. As the say goes, 90% is in the planning and 10% is in the deed. So the planning is very crucial. You plan, but you try to carry the this kind of on print where the incisions is marked, so that it eases you, because there should not be any surprises on table. So if you can replicate and keep this in your operation theater for anything, any cosmetic, cleft, or anything, this kind of planning will help you to carry out the operation in a very easier way. This girl, we did a continuous W-plasty, and then the angle commissure was preserved. Few things what we need to take care while doing these kind of surgeries are, there is a parotid duct, there is an exposed here in the lower conjunctiva, and then these sometimes you have minor glands along these margins, so you need to excise that. Sometimes there will be hair bearing areas, and you need to really see the commissure on the other side and get the commissure in place. And then this bulge is called commissure bulge, so you need to replicate this. So aesthetically, if you can replicate this, your commissure will look good. And then usually this is the weakest junction where the commissure can open up. So have a mattress here, get the muzzle in place, and then do a W-plasty. So that is the running W-plasty. This is the commonest way to do either wavy or W-plasty to decrease the scar contracture. If you do that, yeah, longevity will be there, and then this can be done. And then this is one of the cases where very initially we thought, yes, the cleft nose is missing. It was our very initial interpretation of this. But if we see that it is malpose, that's all. You have a good alar cartilage. Only thing is you need to relocate it. But during the planning, what I thought was I'll do a nasolabial flap. But once we started doing rotation, we could achieve the symmetry by rotation. So this is after long healing, very minimalistic scar, and I don't think so there's deviation and other things. So, but this child requires midline cranium correction. Meningocele is not there, but there is a cranial defect. We need to do it. And then this is one of the child she had, again, the nose was there. Both sides she had lateral clefts. So This is the complex presentation. This is the girl with all the three characters at a later stage. So, and then this is one of the cases where we had only from the vermilion inside midline cleft. So I always have that fascination towards creation of tubercle. In this case, we didn't violate the vermilion. Just from inside, we removed the mucosa, relocated the muscle, and we could get a good tubercle on the good continuation of Cupid's bow and then good vermilion. Similarly, midline cleft, where in this the patient didn't wanted any kind of touch on the nose. He just wanted only the lip. We suggested to do rhinoplasty together, decrease the ala, decrease the base, and do a projection and then do. But they had concerns, and then we what we did was an elliptical running flow incision, and then the margins were sparred, muscles were dissected, and then tubercle was recreated, and then we got a good continuation of vermilion and this is again 7 lateral cleft running onto the almost towards the ear. So this is the post-op. This child with the lateral cleft, he has missing ear. So the ear reconstruction is the next stage of for this child. This child has neck stiffness, so the intubation was really difficult. Actually, today our anesthesiologist was also, Dr. Hemant was also supposed to be part of this, but because of the emergency surgery, he could not. In this case, he wanted to participate and tell about surgeon's presence during intubation. Only a surgeon can anticipate the difficulty and position the neck position, give a good angulation and intubation. There is, it's a mutual, it is like an faith that if the surgeon is present, the anesthesiologist gets a confidence, and that if the anesthesiologist is present during the time, the surgeons get the confidence. As we grow along, as we become maybe, I don't want to call it as, but a big surgeon, you go to the surgery after intubation, draping and everything. But because most of the students, you are young postgraduates are listening, even till date, I go at least 10 minutes prior to the surgery. Kindly make that as an habit. That gives a lot of positivity in the operation theater. Yeah, this is next stage is for ear reconstruction. This was the bilateral case. Similarly, we did one stage and then second stage. And then so the 7. This girl again, there was eye missing and then collapsed nose and then frontal bossing. Next stage is for craniofacial correction. This is a lateral orbital cleft. This pathophysiologies are different, totally different. In this case, the nostril was recreated. Nasolacrimal duct has been harmed, so we need to do ductal rhinotomy and then do a rehabilitation. This child, yeah, the lateral was very nicely, the child coped up. We had to do the lateral canthal detachment and repositioning to get the lateral canthus into line. If you see if you see closely, you can appreciate this was not in the line. This was slanting. This was detached and it was taken up and then it was done. There was a lateral incision, but it is healed well. So to sum up, the rare craniofacial cleft arises infrequently, but it can be unilateral, bilateral. Surgical management is very challenging because the rare in nature and anomalies, lack of standard care guidelines. The problem of Tessius is difficult to understand. You have to have a diagram at least if you are not experienced enough. And then usually it will be combined. It is not one straight line. It will be a combination of cleft. It is just for the classification, but you have a combination. So the optimal treatment requires multiple stages. First operation is the biggest operation because you are changing the aesthetics. And then perioperative challenge and the post-operative challenge, intubation are all difficult. The second challenge is post-operative. We have a good team, good ICU, then that also can be done. A surgical protocol requires a multidisciplinary team to be there and then to do. And then post-operative airway, yes, that's a question. So the greatest obstacle in the reconstruction of rare craniofacial cleft depends upon the extent of soft tissue hypoplasia and the amount of bony defects. and the vicinity of important structure. This is what the statement has. Almost we are coming to the end. We have brushed through everything, but still a few controversies remain. NAM versus no NAM. Few groups still believe that NAM is very harsh on the baby of a 1 week old, that you are taping and we are giving a nasal hook. Baby is still not accustomed and the parents cannot handle that. But with the experience, what I can say is babies' adaptability is really fast, really good. Babies do adapt well. And it's a matter of time, and ultimately we need to imagine the bigger picture of it, that the baby will be with a very good aesthetic results as well as functional results, and the surgical trauma will be less. And then subperiosteal, as Dr. Pramod has done already, subperiosteal versus supraperiosteal, the consensus are there is no statistical difference between the two, but still it is on the belief of the surgeon and how you carry out. Open killer rhinoplasty versus closed nose. Many of the centers are now opening up for open killer rhinoplasty because the demand or the awareness about nose lip complex is increasing. The children's, the parents are wanting for a good finish at the very first stage. But a few centers have still given the good results with closed nose as well. But we believe in open killer rhinoplasty and we do it. Sequencing of surgeries. In our center, we believe on patient first approach. That is, what is the patient's first, and then function, and then doctor's preference. We don't do because we feel so that stage. Orthognathic versus AMD, we just spoke about it. The really AMD is catching up because of the easiness of the procedure, and then not affecting too much, at least at the initial stages of during the treatment, there is no effect of speech therapy on speech. So the advances and future trends, it will be a team approach. Nobody can do cleft at a single care center in future, at least because of the awareness. Comprehensive cleft care will be a standard. Prioritizing speech is the care standard at a global level. At a global level, less number of surgeries. We need to lessen the burden of care. It is good for the patient, good for everybody. If you have seen our presentation, we have been doing multiple surgeries at one given point of time. That lessens the burden on cost, but lessens the burden on risk, anesthesia risk, healing time, and then the whole duration of an understanding of complex pathophysiology and the multifactorial origin. It is people are going, and we have done a study on nasal cartilages, and then that will be published, and then that might help future coming young surgeons to take up open killer rhinoplasty. So just to brief, this is the for the postgraduates, what questions have come in the regular papers in different universities. Management of patients with cleft lip and palate hole for 100 marks. Protocol for management of lip and palate 20 marks. Cleft palate itself for 10 marks. Lip and palate, topography and facial muscle. Alveolar bone grafting, etiology. Management of secondary cleft deformity. Advances in cleft lip and palate. Cleft rhinoplasty, tongue flap classification, then describe various surgical procedures for correction of lip and palate, current concepts, pushback operation, current concepts, again, classify cleft lip and palate, and then various surgical procedures, 75 marks, secondary alveolar bone grafting, velopharyngeal dysfunction, orthognathic surgery, Millard's operation, Dillard's functional repair. So these are the questions which has come during, I have searched more than, I think, 10 years or 15 years of question papers. If especially for the postgraduates, if you can just brush up these things, you will have, for the exam sake, yes, you will have sufficient knowledge, but to understand the concepts, I think we have shared enough knowledge. This is our hospital at St. Joseph's Hospital, Mysore, where our centers is there. You could get introduced to all our center members today, one by one they presented. At last, what I want to convey is, it is not a one man's job. I am not the only one of the patient. There are many members involved. Each has contributed by their best to get the best of the child. And then to summarize, yes, the cleft lip and palate has throws challenges to the whole team, and each team with interest with dedication, together teamwork, I think we can establish a best results. If personally, if somebody asks me why Cleft, I have choose, I can say it is, I always say that it is 3C and 2S. It's first very complex, challenging, and it requires creativity. And the 2S are, it is one's social responsibility towards society. And then for me, it is very self-satisfactory. So that's how I can sum up. And then this is our whole team. I think few of the people didn't come on the camera, so this is the whole team. We would like to thank our supporters like ABMSS, DCKH, Transforming Faces, and St. Joseph's Hospital for giving us an opportunity to perform this kind of surgeries. A lot of support has been done for the CCC itself, apart from the surgical care. And then so these are my teachers and mentors, and this is my contact in case if anybody wants to get in touch with me or to clarify anything, can approach me. And as at the very beginning, I had told that by the end of our talk, there will be in India, there will be at least 15 left children are already born. They are waiting for somebody to treat. So if anybody has got influence to get into cleft, new childrens are waiting. I think if anybody gets an orientation towards cleft and lip and palate and its management, they get moved towards this, and if they take as a mainstream activity, I think our sharing of knowledge will be, I hope that that will be a success. I would like to thank Dr. Pramod for giving us an opportunity to showcase our work here, and then all the participants and the management has been very kind, and they were there. Usually it will be a little difficult for any management people to be there. They were there. They shared their words of appreciation. Thank you, madam, for sharing words of appreciation to my dean, madam. That was very nice of you. And then, yes, if there is an opportunity, definitely, if the COVID things comes down, I will be really happy to travel also to do some surgeries there. We can do some definite cleft care, any sort of activity in the college. Thank you very much.
Thank you very much, Dr. Manu Prasad. I think, Surabhi, I myself will take over. It was a very nice presentation indeed. You have cognized the budding maxillofacial surgeons and orthodontists and all the other participants related to the cleft craft. And there are some questions. I
Sure.
think, some question is for Dr. Veena. I think the question is on a prosthodontic point of view. What type of expanders can be used for cleft palate according to the age? Is she on board?
Please.
The current question is for Dr. Veena, orthodontist. They have asked that which type of expander can be used for cleft palate according to the age. Okay, I think
in case if she's not there, I'll get the.
Yeah, I think there is one question for Dr. Manu for yourself. That is, I think this is again related to facial cleft. What fills up the commissure bulge? You said that commissure bulge has to be re-established. So there is a question from Dr. Surabhi Singhai, postgraduate. What fills up the commissure bulge?
That is, if we usually see a normal lip anatomy, the commissure starts with a scalloping. So that usually fills up by the muscle, which is adjacent. So when we are doing, so I didn't go very much into technical details because we just wanted to give a gist of it. If we recreate the muscles in either facial cleft or cleft, we have to have wherever there is, if it is the midline tubercle or here, we have to have a disproportional kind of suturing. So if it is straight line, you have to have a disproportional kind of suturing. So this can be rotated and you can make a round elevation. So the same philosophy we follow even in recreation of tubercle in the midline tubercle and as well as commission. It's really difficult to explain by words, but in case if you can happen to join us in someday in future, I will be really happy to show you that.
That's nice. I think we don't have any more questions. Over to you, Surabhi. Thank you very much, Dr. Manu. It was really enchanting to have you, and it was a very roller coaster ride for 3 hours of Cleft Craft. Definitely, most of the students would have been influenced by it. Over to you, Surabhi.
Thank you so much, sir. Thank you, sir, for simplifying such an interesting yet complicated topic, which helped clearing our concepts. It was extremely beneficial for us. Thank you, sir. Now I would like to request Dr. Pramod Krishna, sir, to kindly present a token of appreciation.
This is for Dr. Manu. Thank you very much.
Thank you. Thank you very much.
The next certificate of appreciation for Dr. Veena R.
I think she is not there. Dr. Veena, for you.
The next certificate of appreciation for Dr. Harish K.
Yeah, Dr. Harish.
Is there?
Yeah.
Thank you so much.
Yeah. This is for Dr. Surabhi Atreya.
Thank you, sir.
Dr. Namita MH. Dr. Pratiksha.
Thank you, sir.
Yeah. Miss Anis Fatima.
Thank you, sir.
Yeah. Thank you, everybody. You have also showed that it is a team effort. Like to succeed, you require a team. Yes.
Thank you, sir. As we express our gratitude, we must never forget that the highest appreciation is not to utter words, but to live by them. With these lines, I now request the organizing secretary, Dr. Rajiv Singh, reader in the Department of Oral and Maxillofacial Surgery in our college, to deliver the vote of thanks.
So good afternoon, everyone. On the behalf of Organizing Committee, Department of Oral and Maxillofacial Surgery, Chhattisgarh Dental College and Research Institute, Rajnandgaon, it is a great honor and privilege to deliver the vote of thanks. It has been our pleasure to organize a second webinar, and the second webinar is on comprehensive cleft care, cognizing the concept by Chhattisgarh Dental College and Research Institute, Rajnandgaon. At first, I would like to thank President Sir, Nemi Chand Parak Sir, Secretary Sir, Sanjay Gulcha Sir, Vice President Sir, Sudhir Buddhan Sir, and all CDCRI group. I would also like to thank Dr. Hema Shurivanshi, Dean CDCRI, for continuous support and advice, which we have greatly helped toward the successful organization of this webinar. The lecture, which was given by Dr. Professor Dr. Manu Prasad S. Sir and his team, was informative and boosting our knowledge towards cleft care surgery, and it also gives good idea about the cleft surgery for new upcoming PG student in the field of cleft care surgery. I would also like to congratulate our organizing team for putting such a good show. Last but not the least, I would like to thank for all faculties and PG students for attending this webinar and made it grand success. Thank you all.
Sir, can we conclude this webinar, sir?
Yeah, thank you very much, Manu. So let's all leave.
Sir, everyone is requested to fill the feedback form. The link will be
Yeah.
provided in the respective groups.
Yeah, all of you, please fill up the feedback forms and feedback questions, based on which your certificates will be given to everybody. Thank you
Sir,
very much. Thank you, everyone.
So before conclusion, I would like to request everybody to stand up for national anthem, sir.
विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
With this, we come to the end of today's beautiful and knowledgeable session. I thank you all to make this a successful event. Good day to all of you. Good day, sir.
Thank you.
Have a good day.
Yeah.
Bye.
Bye.